back to a normal page here. Hello everybody, welcome. I'm Dr. Ciapciak, like my friend over here from your guys' group said. Let me try to share it. There we go. Okay, hope you can see everything. Welcome. My last name is pronounced Ciapciak. We've said it a few times. Get used to it. I'm a general dentist. I went to Boston University. I'm a brand new grad, so I'm kind of fresh off the chopping block. If you have questions about going into dental school in the next few years, I just exited, so I have as up-to-date information as you can pretty much get. I practice outside of Boston, so if you guys are in YouTube Live right now and you live around the Boston area, I'd love to have a real shadow, not a virtual shadow, so hit me up. I'll tell you how by the end. Okay, tonight's itinerary, we're going to go through a bunch of stuff. I'm going to start with a general intro, then I'm going to go into kind of a day in the life of me as a dentist and what my life in my office looks like. I'm going to go through a few real patient cases. I know Club Med usually asks for at least one. I'm going to go through at least 3, so it'll be a little bit quicker. I think it's more interesting to see more things. I'm going to do a quick Q&A session at the end, and then we're going to go into a live demo of a composite filling. So stick around for that. The first part's going to be about 50 minutes. The next part's going to be, I don't know, however long it takes me to explain how to do a filling, I guess. If you want to drop out, you can join on my TikTok live too. I'm streaming both here now. Okay. General dentistry, what is it? So you might have heard the term family dentist, you might have heard the term cosmetic dentist, restorative dentist. It's all the same thing. Everyone who graduates dental school becomes a general dentist. If you go on to further training, you can become a specialist. A lot of students when they're in high school or college have only ever experienced specialists, orthodontist, oral surgeon who's extracted your wisdom teeth, your pediatric dentist when you're a kiddo. Those are all specialists. That's the minority. The majority of us are general dentists. So what can we do? You guys are the TikTok generation, so and that's fine. The point of that is that we can do a ton. So we do everything up through Botox and fillers. My class, my dental graduating class, was the first class to graduate with Botox and fillers certification. So I can discuss that again privately. I won't really touch on it much in this lecture, but we do a lot. Hello, it wants to play again. But let's go through how do you become a dentist. I'll go through my story. My dad was a dentist, so this is all pretty clear to me, but it's not that clear for a lot of people kind of as you're working through the timeline. You're all in different places right now in your timelines. You might be a high school student, you might be in the middle of your college experience, or you might be entering your dental school experience. I don't know. So let's go through a little bit of everything and what I might recommend kind of along the way. So if you're in high school, I had the unique opportunity to be a dental assistant starting really young. If you don't have opportunities like that, start shadowing. You're already doing it right now. You already have met a dentist. Shadow virtually, shadow in person if you can. You learn a lot more about patient interaction if you can get someone to show you around in person in a real dental clinic, and shadow a general dentist. Again, 80% of everybody in the dental field are general dentists. Call your parents' dentist. That person would be a general dentist. If you want to become a specialist, that's great, but you're going to have to work your way through dental school first and learn all the things that dentists do before you then taper that down to become a specialist. So shadow a general dentist first. I think that's the best way to get a broad idea of if you like the field as a whole. I also want you to stay in your extracurriculars, do stuff that you love. Dental schools really do want to see that you're well-rounded. So if you're on a sports team, stay on that sports team. If you love art, stay doing art. If you love music, there's a lot of research that supports people who are good at science or really good at music. Stay doing that stuff, makes you more well-rounded. Fine motor skills, super important to start doing something that you can hone in your fine motor skills. This is not something that anybody told me. I happened to pick up knitting in high school-ish. My grandma taught me. Do something that you're using your hands in a really small, fine way. Calligraphy, knitting, sewing, video games counts, Legos, building small things. They will ask you that on your dental school application. And if you're Canadian, I don't know, if I have people throughout the world following this on YouTube right now, they'll actually test that on your dental admissions test if you can use fine motor skills. So start young if you're able to do that and really get to practice that. Literally your app will say, what is the thing that you do for practicing your fine motor skills? Keep your GPA up as much as possible throughout the whole experience. I'll talk about kind of general numbers that you should have. We'll get to that. If you're a freshman in college, keep shadowing. Continue to shadow as much as you can every summer, every weekend if you can. And you're going to want to take a certain group of courses. So I'm going to go through all the courses that you're going to need to even apply to dental school. They're all in purple if you want to, screenshot this at the end. But you're going to need to take your Gen Bio 1 and 2, Gen Chem 1 and 2, and your English 1. You also should probably join a pre-dental club. It shows that you're interested in the field. Say you're unsure, maybe you want to become a dentist, maybe you want to go to med school. Join both. Continue in both, and then it shows both programs that you have had interest in them, since early on. Sophomore year, you're going to want to continue those gen ed courses, or kind of those science specific courses that you're going to need to apply to dental school, those prereqs: organic chem 1 and 2, genetics, and English 2. So dental schools, I'm not sure about med, dental schools do require an English composition class. I didn't know that. I actually didn't have my credit for that. I was sitting in my dental school interview at BU, and the faculty said, Ashley, I don't think you have your English composition. I freaked out. I did have a course that qualified, but write these down because you don't want to miss out on those. Try volunteering. Try to reach out into a dentist or a Doctors Without Borders group or something like that. Volunteer, get out of your comfort zone and try to help. Dental schools and medical schools similarly both kind of expect that nowadays. I'm sure you experience that applying to undergrad too. It's getting harder and harder to get into undergrad schools, similarly to get into dental schools and med schools. So volunteer, it can help you stand out. If you like research, get into research. That's a good time to start. Sophomore year, a lot of research labs will start accepting you guys. I hated research personally. I never did any of it. Didn't do any research in my undergrad nor throughout my dental school experience. So don't ask me about research. You don't need to do it. It's just if you're interested in it, that's a good time to start. Continue that pre-dental club. Junior year, you're going to need to take physics. Yes, you need physics for dental school. I don't know if that's true, again, about medical school. There's a lot of physics in dentistry, bite forces and material sciences and different opposing materials and orthodontics. If you want to become a braces specialist, that's all physics, all vectors and things like that. So you'll need that course too. And you want to take all those courses before junior year so that then you can take your DAT, your dental admissions test, between junior and senior year. Study abroad if you have the chance. I loved that experience. Again, it kind of rounds you out as a person a little better. Junior is when you also start asking for your letters of rec. This is not something I was aware of that we even needed. But now at this point, you've already shadowed, you've already met a bunch of dentists. You do need a general dentist to write one of your letters of recommendation for dental school, not a specialist. This is super important. So start shadowing that general dentist in high school. Again, continue research, continue pre-dental club. Senior year, you're going to finish out your major and minor, whatever you decided to major. And notice I didn't say major specifically in something. My best friend in dental school was a clarinet performance major. You can really be anything as long as you take all those courses that I highlighted in purple. They don't really care. Other classes that might be helpful that I wish somebody had let me know early on, anatomy and physiology. Dentistry is really anatomy heavy. I'll discuss that a little bit in my filling preparation section, but all the nerves that I'm aiming for, I can't see. Every time I put a needle into somebody's mouth, I can't see those nerves. I can't see those veins that I might hit if somebody draws your blood. For example, the nurses might be able to see that. We can't. We're going blind. I'm going fully based on anatomy and my landmarks on head and neck anatomy in order to aim to get those injectables into the right place or those anesthetics into the right place. I wish I had taken a course in undergrad. I jumped right in to anatomy in dental school. It's a steep learning curve. Physiology can also be a pretty steep learning curve if you haven't taken that course before. So try to take those if you have access to those. Histology is super boring, personally to me. If you love it, That's great. I didn't. Histology is the study of microscope slides, basically pathology under microscopes, well, normal tissues and pathology under microscopes. Again, this is a course that becomes super important in dental school, but if your college offers it, it's going to really help you out if you can take that out before dental school. Embryology too. Embryology is a steep learning curve. Genetics as well. It is, I'm pretty sure, a requirement. I should double check that. I'm like 98% sure it is a requirement anyways for dental school, but definitely take those things. Okay, back to timeline. Between junior and senior, you're going to take the DAT. You can take it at any different time. I know it's a little different right now because of COVID. Biggest, most important thing, if you're going to take away anything, you guys are all going to put this part in red in your little write-up for Club Med, because it's super important. If you are applying for dental school, submit your application like the first day that it opens. If nobody's told you that, and I'm the first one telling you that, write it down, make sure you highlight this, screenshot this, whatever you need to do. Remember to submit your application really early. Dental school admissions is rolling admissions. So a lot of people might see that and see, oh, the deadline for an application is due in March. I don't need to apply until, March of the year that I'm trying to start dental school. That's not true. How they do it is the first group, basically, if you submit your application on day one and you have, less than perfect grades, because none of us are perfect, they're going to see your application first. Then they're going to go, in order of how they've arrived, they're going to start filling those seats right away. So you don't want to submit your app late. The later you wait, the more seats are filled and the more people who have already interviewed. So get that app in as early as possible. That'll be between junior and senior year of undergrad if you're trying to go straight through. Senior year, you'll start doing your dental school interviews in the fall. If you have much higher grades, you'll continue those dental school interviews through January and February. Acceptance is usually around March for dental schools. So you'll get accepted, hopefully. Between your senior year of college and your matriculation into dental school, again, something I wish somebody had told me was how short that summer is. That is the last summer that you're going to ever have. Once you start dental school, it's basically a full-time job. And what I mean by that is BU Dental, where I went, for example, we had 2 weeks off for the whole year. Our first summer, we worked as a dental assistant for the summer, so we had a little bit more wiggle room, but we had to take a board exam after that first summer. So you really don't get too much time off between or in dental school. It's like a full-time job. If you have friends that are working full-time, you know that they only really get 2 weeks of time off throughout the year. So it's similar. Your senior year is going to end in May-ish. Dental schools start early. They start in like July. Really short time frame. Take some time off. Travel if you have the opportunity to. Don't work. I did. I worked right up until dental school. I worked every summer my whole life. I'll go into that. Don't do that. Take some time off. Take a break. Take a brain break. Take a breather, because dental school is exhausting. You'll work your way through dental school. I'll explain what that looks like. And then you might consider a postdoctoral program. I'll go into that in a minute. But that could add 2 or 6 years to this entire kind of experience. So screenshot this if this is not something that anyone's ever showed you before. I think a timeline like this is really helpful to kind of make sure that you're on track with certain courses and kind of when things happen. Okay, what is dental school like? You guys are all probably wondering this. You all probably watch YouTube videos on, I'm a dental student, I'm a first year, whatever, if you're, further on in the course. This is my bulldog. His name is Flapjack Ciapciak. Shameless plug for his Insta. D1, your first year of dental school, you know nothing. First year of dental school is you basically drown in books. Your first year and second year of dental school are paralleling with the first and second year of medical school. Some dental schools actually tag their dental students and their medical students together in the same courses. They just take the same exact classes together. Along with you're going to retake genetics and biologies and microbiologies and physiology, anatomy, things like that. Something I wasn't prepared for is, again, how steep the learning curve is. It's something that you will be able to conquer. I promise you that. They wouldn't accept you if they didn't expect that you would be able to do well in dental school. But it's a steep learning curve. So you'll learn how to study. You might modify your studying behaviors. How BU operated is we took courses from 8 a.m. to 5 p.m. and we had exams every 3 or 4 days, which sounds crazy. It was crazy. I didn't sleep much. You study a lot, but you do get used to it, and it's very doable. Second year, they start to add on preclinical courses. So today, our filling is not going to be on a live human. I couldn't get my patient to come and sit for this late at night. But you're going to start practicing on typodonts, or kind of false teeth and false heads. That will teach you all the things you need to know to go into then third year. Third year is going to be clinical experience. You're going to practice on each other. This is me and my best friend, and I'm teaching a younger classman here, an underclassman. Third year will kind of bleed from preclinical into clinical. You'll practice first on each other, like I said, then you'll have your own patients, and then fourth year, you're treating all your own patients all the time and taking your live patient board exams. Postdoctoral programs, should you specialize? I chose not to. I'll go into that a little bit. But if this is something that interests you, I'll go through a little bit about that. So general dentists, someone's going to ask, so I'm going to go through the salary. On average, general dentists make about $130K to $200,000 a year. It depends on your region, depends on your area, depends on kind of what you produce, meaning if you're doing all fillings, you're going to make on the lower end if you're placing implants and doing a high volume of crowns or kind of higher yield things, you'll make a little bit more. Or if you hire dentists underneath you, you'll make a little bit more as well. Specialists, on the other hand, go to school for a little bit longer. They're going to make pretty much significantly more, double almost. So think about your orthodontist, your pediatric dentist. They're going to make a lot more than I'm going to make because they went to further schooling for that. They went to specialty training. Again, 20-ish% of dentists are those specialists. And you need top grades in your dental class to even consider applying for specialties, of course, but it's very doable. Highest paying, you got your oral surgeon. They're always the highest paying. They make about $400,000 a year. Endodontists are people that specialize in root canals. They deal with pain management as well. High stress job. And orthodontics, they make a lot. Lowest paying is periodontics. They do gum disease and kind of bone disease and bone grafts and implant surgeries and things like that. I'm going to click through all these in case you're interested in them. I'm not going to go through them all. These are all the currently accepted specialties. You can look them up and kind of look into them if that's something that might interest you in the future. Okay, there are other things. So 4% of people applying to dental school actually get into dental school. That sounds like a scary statistic. If I can do it, you can do it. I literally promise. Acceptance into dental school is a little bit lower than acceptance into medical school. Similarly, acceptance into veterinary school is a little bit lower than acceptance into medical school right now, probably because there's just less vet and dental schools in the country. People are really interested in both fields. There's a lot of stability. I can own my own clinic, run my own office and things like that. There's a big draw for dentistry, right? So again, that number is about 4%. Certain schools accept, closer to 10%. BU is a little bit tighter. If you don't get in, what can you do if you love this field? You can become a dental hygienist. So you need an associate's degree to become a dental hygienist. They get paid pretty darn well. In my area, they get paid about $51 an hour, which is significant. A lot of dental hygienists, the con is that they don't usually work full-time. They usually work 3 or 4 days a week. And they don't usually get benefits just because that's how our field kind of is about that. You can always ask for benefits. Dental assisting, you can become a dental assistant with a 9-week course after high school. They're going to get paid less. They have a high school degree and then kind of that dental assisting training. There's specialty dental assistants as well. They can do a little bit more. They take a little bit more of a course. Used to be able to be on the job trained. I don't think that is a thing in any state anymore, but I could be wrong. It's definitely not a thing in Massachusetts anymore. Mid-level providers. Again, if you don't get into dental school, you might become a dental hygienist or something, and you might say, I don't feel fulfilled. There are some states now that are accepting mid-level providers. Basically, they're trying to gap there's a gap in medicine where people aren't able to access dentists as much. These mid-level providers, the whole point of them is to try to bridge that gap a little bit, make dentistry a little bit more affordable. They get paid pretty well. Dental lab technicians, I put them last because the field is changing. Basically what they do is they fabricate crowns and dentures, and I'll go into all of those things in a few minutes here. It's changing because we're 3D scanning things and 3D printing things and milling things now more and more and more. So I'm unsure how that field's going to look when you're applying. So I put them last because they're a little iffy there right now. My dental journey. You guys always are going to ask about this. I started really, really young. I was a dental assistant, trained on the job at age 13. Yes, child labor laws, whatever. I worked for my dad. I suctioned, spit, and that's pretty much all I knew how to do. I was trained originally so I could go to India with him and run a dental clinic with him there. We hired local dentists in India, in Hyderabad, if you're familiar with India at all. And we run a clinic there for the past 10 years for HIV positive kids that don't have access to dental care. This is their Instagram. If you want more information, I run their Instagram too. We stand a social media queen. I've been going my whole life. I will continue this. So again, if volunteering trips like this are something that you're interested in, shoot me a DM on this Insta or shoot me an email or anything. I'll give you my contact information at the end. We're always looking for volunteers for trips like this. It's a lot of fun. You learn a lot. We do a lot of dentistry for a lot of really cool kids. After doing all that every summer for like my whole life, I went to Villanova. I continued again going through to India every summer during during undergrad. Went to Villanova, won the national championship in 2016 when I graduated. Then I started dental school. That was my first year, my first day ever holding a handpiece. So cute, I know. This is, I think, also first year. You practice first, like I said, on these freaky mannequin heads. And then slowly the mouth gets smaller and smaller. So in the first picture, you'll see it's propped wide open. It has no skin on it. Then they add skin to, help you practice retracting skin and tongues and things like that. Then we practice on each other. So this is my best friend. In this picture, I think she was probing my gums. So she's taking some gum measurements. We did stab lab together. We numb each other. Again, you have to practice on each other before you're going to practice on a real human, like your actual patient, somebody from the public. So we numbed each other, and you get numb in weird places that you didn't expect. So that's why my eye's a little twitchy in that picture, and my friend's lip is draping a little bit. So it's a good time. I graduated in a pandemonium. So like I told you, graduated in 2020. We didn't walk at graduation. I had really no pomp or circumstance. I just walked out of the building one day and didn't realize I was never going to walk back. So that was my last day on BU's campus. I had to go back a few weeks later and clean out my locker, and that was it. This is my office where I'm sitting right now. It's kind of weird. That's me and Dr. Brede. He's my dad. We run a small family practice outside of Boston in Needham, Massachusetts. But we are expanding. So this is my brand new practice, my brand new sign. We're literally moving. This is our last day here. So I set all this stuff up. My staff's going to kill me because we're moving everything out tomorrow. So yeah. That's a little bit more about me. My stats, if you guys are applying to dental school like now, or you're thinking in the next year or so, these stats will make a lot of sense to you. If not, just ignore this slide. My high school GPA was 3.3. I don't think that's super great. I did my best. I didn't take any AP classes. Actually, I took AP Psych, but I didn't even use the credit. I wanted to experience my high school, so you don't need AP classes. They might help you. My undergrad GPA, I barely scraped by my senior year with a 3.5. My science GPA was 3.25, so that's decent. Dental schools expect you to have around a 3.5. So I was kind of considered in the middle. It depends on the dental school that you're applying to, of course. I'm going to speak to primarily the Northeast schools. I'm from Boston. So I was a little bit on the low end for BU. Actually, I think BU's cutoff was 3.6. I snuck in, I guess. I don't know. I barely graduated with honors. DAT, again, if you've taken the dental admissions test, these numbers will mean something to you. If not, that's fine. You can ignore it. There's a range. It ranges from 1 to 30. 30 is a perfect score. I've never met anyone that had a 30 in any of the sections. The most important section is your reading comprehension section. We have natural sciences, so your biology, your gen chem, your organic chem, and your perceptual ability test, which is 3D objects and 2D images and stuff like that. Reading comprehension statistically is the only section that actually has any correlation to how well you'll do in dental school. So if you interestingly go back and watch other dentists, for example, on Club Med, most of us have a super high reading comprehension rate. You need to know how to read and understand what you're reading because we're inundated with information all the time throughout dental school. We work our way through textbooks really quickly. For reference, my microbiology course in dental school, I took two microbiology courses in undergrad, an upper level bacterial pathogens course and a general microbiology course. Both of those courses were covered in about a week in dental school. So you have to read a lot, you have to be good at reading, you have to understand stuff quickly. That grade is really important. So start reading now, read books for fun, you'll get that score up. Dental school GPA kept going up. At this point, I was basically a professional student. So most of my classmates, my friends had pretty high GPAs because we kind of knew how to study by then. Okay, that was general intro. The other parts are pretty short, actually. So day in my life. What does my life look like here in this dental office? Told you we're moving, so don't judge my ugly office. I know. We're gonna work right now. We're working a tighter schedule because we're in COVID time. So we're working 7 a.m. to 3 p.m. and not breaking for lunch because that's when COVID can spread to each other. So we're seeing about 8 to 10 patients a day. I do a ton of different procedures. That's not necessarily the norm for general dentists. A lot of general dentists primarily do crowns and fillings, but I'll show you some cases. This is kind of a quick TikTok of what it might look like my normal day during a pandemic. I always have coffee too. So that's generally what our days look like. A lot of variety in my practice. Like I said, this is a sample schedule. So I might start the day with 2 hours of surgery. I'm doing extractions of all the patient's upper teeth, inserting a denture. But at the same time, so all of them say my name because I didn't want to expose patient information. So that's why it says my name 100 times. Op 2, for example, is my hygienist schedule. She's in blue here. She might start with a deep cleaning and then do a normal cleaning and then take some x-rays and then along with her cleaning, so you can kind of read down periodic exam and prophies and cleanings. I might have an emergency patient and I was booked in op 3 and I have to run over there while this patient's I'm waiting for this patient to stop bleeding. They're biting on gauze. Now I might start a root canal in operatory 3. I've numbed that patient, but my patient for 9 o'clock is early. Now I'm numbing this one. Now I'm going back to this one. And now I have to stop in the hygiene office and make sure that, I do my quick exam there. So there's a lot of back and forth. There's a lot of brain switching throughout the day. If that's not something that you're good at, general dentistry might not be good for you. I go from surgery to root canals to emergencies where I don't know what they might need, to fillings, simple fillings. I do crown preparations. I might jump to a new patient exam, which is totally different because I've never met this person in my life. Every day is super different. Every procedure is really different. Every tooth is really different. If you're not good at that, this might not be good for you. You might work your way through dental school and say, I'm only really good at root canals, whatever it is. That's when you can become a specialist because then you only do root canals all day long. You always know what's coming in the door. How we schedule, we put together treatment plans. This is a sample treatment plan in my own chart. Again, I can treatment plan extractions. I can treatment plan different things kind of based on when they should be done. Then my front desk takes that information, plugs it in based on how long I've set for that procedure to take, basically. So this is what our charting system looks like, if that's something that's interesting to you. Real patients, let's get into the fun stuff. Let's do some cases. All right, so I've started them from easy to hard. First one's the most in-depth one. This patient presents, so I'm just gonna kind of go into it. I'm gonna talk a little bit above perhaps what you might understand. Try to follow along. This is the kind of depth that you're gonna need to discuss in dental school, so I think it could be interesting if you've taken any of these things before. You might already know some of these terms. This patient presents, he's 63, he has GERD with Barrett's esophagus, GERD, gastroesophageal reflux, does play a role in dentistry. It floods the mouth with acid. It can cause erosion. This patient doesn't really present that much with that much erosion. He has a penicillin, vancomycin, penicillin VK allergy. Everybody has that. It's, whatever, all the baby boomers have penicillin allergies, basically. He takes no daily medications. These are his x-rays. If you know how to read x-rays, they're a little blurry. I'm sorry about that. I guess the screenshot didn't transfer well. He has a lingual bar. That's what you're seeing here on the bottom. It's a bar that connects all the lower teeth to make sure that they don't, move. He has cavities in the upper left side. He's got pretty stable bite, pretty stable fillings otherwise. He does have horizontal bone loss, so he's lost some bone over time. But his gum tissues are healthy. He's lost bone because he plays around with a toothpick all the time. He did admit that to me. Okay, so let's go into some zoomed in pictures. This is one of my real patients and a real treatment plan, and we're going to talk it through. I know you guys are on YouTube streaming, so if you can answer some of my questions, try. Upper right side was stable for this patient. His main problems were the upper left side. So he had some recurrent decay. This is the tooth I'm talking about, this first picture. He had a filling done. It was done poorly. The seal is bad, and I can tell that because there's a stain around the whole thing. It was, starting to chip. It just wasn't holding up well, and it was just done like 2 years before. It's taking up a large surface area. So the question here is, should we do a crown? Should I cut more tooth structure away and try to fully cover all the cusp tips, or should we try to refill this? So try to answer. Question 1, do a crown or do we refill it? Question 2, the next tooth that he has a problem with, tooth number 20, which is the lower left second premolar. He had actually my grandfather placed this particular filling, this disto-occlusal dio amalgam, but he has some cracks kind of radiating from it. Again, can I refill this safely? Will those cracks matter? What do you guys think? What do you think I should do? Should I stay with the same material even? He's got silver kind of everywhere, if you can't tell. He only had one tooth colored filling up here, and it already has recurrent cavities. Should I stay with silver? What do you think? Number 2, crown or refill? Number 3, tooth number 31, this backmost lower right backmost tooth here. He chipped off an entire cusp. I don't know how he did that. That's not usually a strong biting cusp, but somehow he fractured off an entire cusp. Obviously his bite forces back there are pretty strong. Should I fill it? Should I patch it and kind of build that cusp back up with some sort of filling material? Should I try to crown it? Any answers? Throw them my way. I don't know if Club Med's getting any answers coming in, or if anyone's afraid of me to answer these questions.
There is a lot of...
List them 1, 2, 3. Vote crown or refill, crown or refill, crown or refill.
A lot of crown. Second one is
okay.
Crown. First one's refill. It's like mixed between the two.
Okay, interesting. 50-50, we don't know. This is why we're here, we're learning.
Crown for 3. Refill.
Well, maybe this will help you. So let's go through indications. When would we crown? I would crown if the existing restoration is taking up about 50% of the bite surface. So occlusal table is this, the biting kind of table. If that existing restoration is about 30 to 50%, we're going to consider a crown. So this first one, it's about 30. It's actually like 80% of the bite surface. So we're probably going to lean towards crown on that first one. If there's a cusp fracture, we know the bite forces are strong, we're missing an entire cusp, we might consider a crown so that we can rebuild that cusp. If the tooth was endo-treated, if it's had a root canal, in order to do a root canal, we have to core through the middle of the tooth to access the nerve space. On back-biting teeth, we always do crowns. Crowns are always indicated for root canal-treated teeth in the back, not in the front. If the tooth is cracked, okay, someone was saying 20 DO, we should consider a crown there because it's cracked. There's little graze lines, little cracks coming from that existing filling. Might be a good idea to consider a crown to kind of tuck everything back in together. Clenching and grinding, excessive occlusal forces. 60% of Americans clench or grind their teeth. I do it. You guys all probably do it because you're all probably super anxious. My whole generation is really anxious. You probably don't sleep because you clench and grind your teeth. Get checked for that because it tends to flare up as you get more stressed in school. Filling indications, we're going to do fillings when the cavities are small or when I can access them and kind of barely cut away tooth structure basically, or if the cavity is less than, again, that kind of general percentage of the bite surface. There's going to be different crown materials. I'm not going to go too deep into this. This is all stuff you'll learn in dental school, but there's different amounts that I'm going to have to cut away the tooth structure in order to prepare the tooth for a crown. Full gold crowns are going to be our least invasive crowns. I only need to cut about 1 millimeter of height, kind of 360 degrees around the tooth, in order to slim that tooth to receive a gold crown. Porcelain fused to metals are the next most invasive, basically. I cut about 1.5 millimeters, 360 degrees around. All ceramics are pretty beautiful materials. Our zirconias are Emax, if you've heard any of these names before. We're going to really dig away tooth structure for that. We're going to basically cut away 1/3 of the tooth, slim it down by about 30%. In order to allow for that material thickness for those materials. So, there's also 2 different filling materials if you didn't know, silver fillings and tooth colored fillings. They're indicated for different things still to this day. Statistically, our research supports that silver fillings last longer in the mouth, especially on backbiting teeth. They last 10 years on average. Tooth colored fillings last 6 years on average. I'm sure those numbers are going to change and they're going to go up, but dentists always choose silver fillings in their own mouths. Patients always choose tooth-colored fillings in their own mouths. It is what it is. We know the research. They don't listen to us anyways. Okay, so what do we actually do? 14. I didn't give you the option for an onlay, so I know this is kind of cheap. Sorry. Tooth number 14 had a big filling. I treatment planned with the patient. I agreed with you guys who said we should do some sort of a crown or some sort of a full coverage restoration. It's too big of a filling. I don't trust it anymore. I don't think I should refill it. I think that the cusps would become weakened if I refilled it. So I went for a gold onlay. Basically what that is kind of a shorter crown. Basically a crown. Lower left side, I actually refilled this. It does take up a significant amount of tooth structure already. It's about 50%. This patient didn't have any cavities in that. It was just a broken filling. And those radiating graze lines that you see were just with an enamel, so we can shine a light through that and see if there is, if that crack is deep. It was not. So I'm not that worried about it. As people get older, they have graze lines. That's what we call them in their teeth. If it's a true crack, there's usually symptoms associated with it. There was not in this case, so I actually chose to refill it. Lower right side, this patient fractured off the entire cusp. I want to rebuild that cusp with something. So on the left, you'll see what he had. On the right, you're going to see what work I did for this patient. The only questionable work I did was tooth number 20. I probably should have done a crown looking back. I did extend it. I know this patient. He's actually my dad. He's a dentist. So if he breaks this, he's going to be back in my chair the next second. No big deal. Questionable though, because tooth number 20, the back half of it is a silver filling and it's right next to a gold restoration. We don't do that in dentistry. He knew that. He chose silver filling there. It was his choice. He actually asked for that treatment. I wouldn't do this necessarily in a normal patient because sometimes that silver filling can actually conduct electricity to the gold restoration behind it. So that's a risk. Happens about 3% of the time that those two materials join. I wouldn't even take that risk in any live patient, basically. So this is a dental treatment rendered if you want to see before and after x-rays. So for example, tooth number 31 got a full coverage crown. You can see that the cusp was broken off and I rebuilt that whole cusp. Tooth number 14 and 20, you can see in the pictures on the right. I again went ahead with gold because gold is opposing gold here. Similar materials oppose each other similarly. They will wear each other wear into each other similarly. So if a patient has metal, I'm going to oppose it against metal. I'm not going to put porcelain against gold because porcelain is going to wear significantly stronger into gold. So those are all things that you'll learn, things you have to think about with each individual patient. So that was the easy case. Gets a little harder when the patient has no teeth. So removable appliances is another thing that general dentists do. We do dentures. I love dentures. Not everybody does. This patient presents to me with some funny looking teeth. That is not a real diagnosis. This patient had periodontal disease. All of her front teeth had lost so much bone. So periodontal disease is basically gum disease that's gone on for too long, and the bacteria have snuck their way up the root, and this patient was unable to afford dental treatment for about 30 years. She was also very fearful of the dentist. She didn't seek care for a very long time. So by the time she's in my chair, this tooth number 7, if you're familiar with teeth, it's the tooth that looks all infected and scary. It has kind of a gray halo at the margin of it. That tooth was flailing in the wind. She could speak and the tooth would go like this.
Wow.
Yeah, so this is something that I worked in a federal prison as a dentist too, if that's something you guys have questions about ever. I have great stories from there. She was not an inmate. I worked in a male federal prison, but a lot of those inmates also had similar situations. Their teeth were kind of piano keying. Again, not a real medical term. She was obviously in a lot of discomfort. This tooth was quite loose. What is periodontal disease? This is a lot of smart stuff. Look at the pictures on the left if you're not super interested in PMNs and macrophages and lymphocytes and all that stuff. Basically, if we don't brush our teeth, day 1, we're fine. Day 2, we're fine. Day 3, we're going to get pregingivitis. If I haven't brushed and flossed for 3 days, my gums are going to start to bleed. That's why we have gums that bleed. It's not normal. It's gingivitis. It's an active infection. You have PMNs and macrophages existing already when you have bleeding gums. Gingivitis progresses. Let's continue not brushing and flossing our teeth. Let's go for about 14 days. This is 2 weeks, no brushing and flossing. We're going to have lymphocytes. We're going to have T cells. Your body's trying to fight off that infection. And during that, the bacteria are changing. They're shifting from aerobic bacteria to anaerobic bacteria as they tuck themselves under the gum tissues. Anaerobic bacteria are the really bad ones, the ones that cause abscesses and dangerous things in our bodies, because those ones can exist in cellular tissues, in bone, and in deeper things that are sterile, right? So if we go too long, we get into periodontitis, advanced perio disease. We get bone loss, attachment loss. Those bacteria are basically living deep in the tooth. Look at picture 4, and causing significant bone loss. That's why we get wiggly teeth. So that's what this patient was experiencing, significant, severe periodontal disease. So what do? We extract the teeth that we can't save. Sometimes there's just too much bone loss and I can't do anything about it. That tooth, for example, it was waving the breeze. It had 0 bone attached to it. It was just barely connected by a sliver of tissue. That tooth needed to come out. Sometimes we can do deep cleanings. If it's not the end stage periodontitis, we can clean the root, scale off that bacteria, remove all that bacteria, and sometimes that tissue will tighten back up. The bone usually doesn't get back to a normal place, but sometimes we can really help with deep cleanings. We have to keep these patients on tighter cleaning schedules because they've already experienced those anaerobic bacteria, so they already have a tendency to have flare-ups more than people who haven't had those anaerobic bacteria in their mouths. So these patients need to have their cleanings every 3 months or so. Okay, so what do? This patient needed dentures. I couldn't save any of the upper teeth. It was a really sad day. She was quite young. She was 46, what did I say? Something like that. Couldn't save any of the upper teeth. I fought for the lower teeth. She didn't have as much bone loss, so I haven't been able to follow up with her. She was a school patient of mine. We do them, again, if we have missing teeth already, if the teeth are hopeless, if dentures are cheaper than doing implants or saving all the teeth usually. It'd be contraindicated if they're allergic to dentures, if they have a severe gag reflex, sometimes we can't do it. Super old patients who've lost a lot of bone, sometimes the dentures just won't stay in. So yeah, here's her case. I love stuff like this. So again, this is the treatment plan. We just went through that. This is not actually surgical day. You wouldn't want to see that. It's really bloody and gory. But this is what a patient looks like when they have no teeth. This is the ridge, the alveolar process of the maxilla. In this case, if you're familiar with any anatomy, this is the ridge of bone in which we create a suction, and the denture kind of suction cups onto that ridge. Over time, that ridge does decrease because there's no teeth present. There's really no reason for that alveolar bone to stay. So sometimes we jump the gun and we add implants to help the ridge remain present. And this is the denture that she had. So look at the picture on the left, look at the picture on the right. We came a long way. There's still a longer way to go. So the immediate denture is not her final denture because there's a lot that changes. There's a lot of tissue healing. There's a lot of shifting in the mouth after we remove teeth. So she'll wear this practice denture, as I call it, for 2 months or so as the bone really settles down. And then we'll do something really fancy and make digital dentures. Oh, what's wrong with this picture? If you guys can answer it in your chat.
I won't answer it. Let me see the chat.
What do you not like about this? This patient would absolutely love to know that I'm doing this case. She loves stuff like this. She hated this. Can you tell why? I hate it. I think it's so ugly. We fixed it, but it's ugly.
The white on white.
Okay, the white, yeah, that's confusing. Sorry, I didn't explain that. The gums look white because it's a try-in denture. The company basically 3D prints them like this so that you can't like steal them. It's so stupid. I think it's wrong. And then they 3D print it with pink as the gums. So yeah, I agree with that. That's ugly, but it's a try-in, so that's why.
The gums don't match. The gums are showing.
Are the teeth too small? The lip looks kind of pushed out, right? The lip is arched this way. Her smile is like a football, so I can tell that the lip is pushed out. The gums look puffy. They kind of look bulbous. It just is bizarre. I don't know where they got this rendering from. It is not like anything I sent them, so I was really upset with the lab this day. So I had to send corrections. This is the problem right now with transitioning into the digital age of dentistry and medicine, is you're going to have issues like this. So if you guys are interested in medicine, they 3D print different body parts all the time. This is the denture version of that. So we had to make corrections. We took some measurements. Like I told you, I hated how short the teeth were. They're short and square. She does not have a square face. She has an oval face. The teeth should look more oval shaped. I think they look like chiclets. You'll notice that the denture that I made, the pink one, is much shorter. That was much more comfortable to her. The denture that was fabricated by the lab, by the new impression that I took, was super long, way too long. It was pushing the lip way up like this. That's why we were getting that weird arcing formation. So they needed to adjust that. I put pictures next to each other so they could see the height difference and how badly they screwed up. Also, the midline was way off. So if you look at the picture on the bottom and you track her nose to her chin, her nose and her chin are super aligned, which isn't that common. Usually someone's nose is pointing one way and their chin's pointing the other way and their midline's somewhere in the middle. Now you're all going to look in the mirror tonight and hate me for that. But she's pretty aligned, and the teeth are shifted all the way to like the left by like 3 millimeters. It looks like trash. So we made all those corrections. I don't have a final picture for this case. She did look great at the end. These were kind of my working pictures to the lab. But dentures can be absolutely life-changing. This is a different patient. He was 35. He was in a coma for a long time, wasn't able to care for his teeth. I love dentures because I brought him from that to this. And that was just the tooth try-in. That's in wax. So those teeth were not even in their final kind of acrylic form. The bite marks that you see are just the bite marks. I had a lot of patients that presented like this when I worked in a federal prison. And unfortunately, if their sentences are too short, we don't fabricate dentures for inmates with sentences less than 3 years in federal prison. That's heartbreaking. If I can get them to that, I love dentistry for that reason. Okay, other things we can do, fun stuff that I love doing. I love surgery. A lot of people, as they work their way through dental school, they'll say, oh, I want to be an oral surgeon. A lot of first years really want to be an oral surgeon. Oral surgeons are the top like 3% of your dental graduating class. You really have to be ranked like number 1 through 10 in your dental graduating class. Yes, we have rankings in order to even really consider oral surgery seriously. But that said, you can still do a ton of oral surgery if you're a general dentist. I love doing it. So these are some implant placement surgeries that I did for this one patient, 3 implants. You basically peel back the tissues. I know you guys love gory stuff, so I had to throw this in. You peel back the tissue, you peel it back to the periosteum. I'm looking right at the bone in this top left gory picture, and I'm holding it back just to take the picture. The patient was super kind about it. Same thing on this upper right picture. You literally drill them into the bone. I don't have a model here. You drill these guys into the bone, you let them sit, you let them heal, and then I can build upon that. Okay, quick Q&A. We have a few more minutes before I said I would go live on TikTok, and then we're gonna stay on this, but we're gonna start our filling demo in a few minutes. So shoot me some questions if you have them, and we'll round out this presentation. Follow me on all my things also. Some of you guys tried to follow me on Instagram. I don't let anyone follow me on my private Instagram, but follow me on my Brede Ciapciak Dental, DM me anytime.
There you go, guys. Follow her on TikTok, follow her on Instagram, and if you guys have any questions, you can always email her. I do have a few questions for you.
Sweet.
How long was the patient that was in coma? How long was he in coma for that?
So that patient, a really interesting case. He was in a coma for in 2008 till 2009, so one whole year. His girlfriend tried to kill him. She drugged him, and he went into a coma, so no choice of his own. He came out of the coma with significant fear of people, so agoraphobia for obvious reasons. His girlfriend tried to kill him. And so he didn't leave his apartment for 11 years. And I saw him a few years ago, and I actually did that entire case in his apartment. So he wasn't even able to leave his apartment to get any of those denture fittings done. He did have to leave under sedatives to go and get the surgery done. Yeah, so really tough case.
That's so, like,
it was heartbreaking. Yeah, that was a sad one. But now he has teeth to smile with, so that's good.
He's got a really good smile now.
He's young. He was 35. Too.
He's 30. Yeah, he's young for him to have that. Another question. This is a quick one. What did you major in undergrad? I don't know if you already said it.
Oh, I didn't say that. Yeah, sorry. I was a biology major with a psych minor. I did psych as a minor just because it was fun. I loved biology, but you don't need to do a science major to go into dental school or med school. I actually think it might help you to not do like a biology major, because everyone kind of does that, because you get all your prereqs as part of it. I didn't realize that. I had a lot of friends that were business majors and other things. I think that kind of gave them, it helps the school get like those numbers in. They want to see diversity. So I was just the normal one.
Gotcha. For somebody who's applying to dental school, how many dental schools would you recommend applying? Or you could also share, like,
good question.
You apply to.
Don't apply to dental schools that you're not interested in going to. I would say that first. So I applied personally to, I think 10 or 12. I forget off the top of my head. I applied only in the Northeast or East Coast. I applied from Boston to Virginia, basically kind of up that whole East Coast. I knew I didn't want to go to some random Midwest school. No offense, Midwest. I just didn't want to go there. My family and everyone is here. My practice was going to be here. I applied to like 10 or 12, and I got into 2. That's not normal. Most of my dental school class, BU Dental is ranked like number 8 or something in the country. They're ranked pretty highly. And still, most of my dental school class had only been accepted by BU, and then they went to BU. That's pretty normal. It's not super common to have a bunch of acceptances. If you guys are on Student Doctor Network, you probably are seeing all the kids with, perfect scores, and they're like, how many dental schools did you apply to? How many did you get into? Don't compare yourself to others. Most people get into 1 or 2. I got into Tufts and BU, interviewed at both and chose BU for a whole slew of reasons. If you're between the 2, I have an Excel spreadsheet if you want me to share it with you. But yeah, that's kind of average, I'd say.
We'll do another question. I think this is a good one. It says, like, if let's say you graduate dental school and years later you want to specialize, do you think that's possible and you can go back and specialize depending on what you want to do?
Definitely. And I think it's a good idea because you can also start paying off your loans. So that's not something you're really touched on. Here, dental school is really expensive. So undergrad, most people are graduating undergrad paying, if you're in a private school, if you're in a state school, you're going to pay a lot less. If you're in a private school, you're paying $50,000, $60,000, maybe $70,000 a year. Dental school is about $100,000 a year. That sounds really scary. I don't mean to scare you, but you should know those numbers. because a lot of students come out of dental school with upwards of 300,000 plus in loans, and those loans might be at 8%. If they're having federal loans. There are programs that you can get those loans forgiven if you, again, work in a federal prison or something like that. But those numbers are expensive. So a lot of people do go, work for a little bit as a general dentist and then go specialize. That is something that happens. The only field that doesn't love that as much is oral surgery. I don't know why. They seem to like when students go straight in, at least from what my friends have told me. But yeah, that's definitely possible. But think with me, if you're going to get paid twice as much as that specialist, it would probably make a lot more sense to just go straight through. Most general dentists, you can pay off those loans, that big chunk of loans, in about 7 to 10 years. It's very doable. If you're going to be a specialist, you're probably going to pay that off. You're going to do a little bit extra schooling. You're going to pay maybe another $100,000 or whatever it is. But you're going to pay those loans off faster because you're making almost twice as what I'm making. So.
Makes sense. Running low on time. Is there anything that you would like to add? Any last bit of advice before you go for somebody?
Do your best, try your hardest, and do the right thing. Don't cheat.
Oh, guys, there you go. Work hard and everything will be possible. But I do want to thank you for taking the time for coming and talking about dentistry. I mean, I learned personally a lot of information. I think so did the audience. I mean, there's a lot of questions, but I can only get to so much. But
DM me.
DM her, guys. Go ahead. DM her on Instagram, and she'll get back to you guys.
DM me on TikTok, Instagram, whatever.
Exactly. And if you guys have any questions, DM her. Or if you guys have any questions for our program, for Med, DM us too, and we'll help you guys out there. And if that was a session for you, we're glad. But if you want to learn more about different fields of medicine, we'll have calls every week. So be sure to stay updated with what we're posting on Instagram. And you can always sign up for email reminders, like I said in the beginning. But that is it from you guys. Thank you so much, Doctor.
Yeah. How do you want me to do live demo? Do you want me to stay on this call, or do you want me to just do it on?
Yes, the live demo. I forgot. Go ahead. Yes. Go ahead.
Okay. I know people are probably itching to see it. Just kidding. Okay, so this is the case. Let me go live on TikTok in case anyone's following me on TikTok already and you want to watch there.
I'm so sorry. I totally forgot about this demo. You got into
You're
questions.
fine. Don't worry. Okay, so I'm going to talk you through everything. This shouldn't be super long. It's going to be a pretty easy filling. This patient here today is presenting. She's a 26-year-old female. I made her myself. Actually, I'm not 26. I'm older than that. Whatever, 26-year-old female. She's taking Dilantin. She's using a Pro Air inhaler. If you guys know anything about those medications, Dilantin is an anti-seizure medication. Patients do have seizures in our chairs. That is a medical emergency that can happen. It's super important to hone in on when a patient is taking those medications and just remember what to do if that patient was to have a problem. Pro Air inhaler is an albuterol inhaler. Patients take it for a whole slew of different reasons, but stress of our procedure can sometimes send patients into a shock and they can't breathe. They might need their albuterol inhaler. We have it. Sorry, I can't speak. We have it in our medical kit anyways if they needed something like that, but important to remember these things. Also, Dilantin can cause the gums to be really puffy. It's the same stereochemistry, same shape as CBD. If you guys are familiar with CBD or anyone who smokes weed, your gums might grow and get kind of puffy. That's a side effect of that medication. This patient is going to be allergic to shellfish. She has seasonal allergies. I'm not doing any bone grafts here today. I don't really care about the shellfish allergy, but there is shrimp chitin in some of our bone grafting materials, so it's always important to write that down. This patient's presenting with virgin, brand new cavities on tooth number 19DO. So D is the distal aspect of the tooth. Distal is back. If you think of dorsal fin, distal is back. Occlusal is the bite surface. So when you occlude, you bite, you chew. So DO is just how we're going to access that film or that cavity. You can see it in this x-ray. There's actually two cavities here present. We're going to access it from the top, and I'll show you how. So I'm going to try to zoom in as much as possible. I know it's probably not going to be super helpful. Oh, I'm going to stop screen sharing so you can see me bigger. Let's do that. So step one, let me find my hair tie. That's really step one. Okay, I guess not. Step one, you're supposed to put your hair up for everything that we do. Don't know where my hair tie ran off to, so if you're a girl, you understand. Every field of medicine, you have to have your hair up for everything you do, obviously. Apparently I'm not doing that tonight, so already breaking the law, starting off good. These are loops. These are magnifiers. I have a light on them. Super cute, I know. They magnify to 3.5 times, so they see much closer, and I can zoom in on everything.
Are you able to like adjust like how much zoom in you want to go into, or it's like automatic?
These are 3.5s. I do have loops that are 2.5, so they're a little bit less zoomed in. They're set at a certain kind of distance. People who are root canal specialists, for example, they're going to be much more zoomed in. They might have 10s because they're looking at really, really small stuff. Okay, this is my patient. This is the tooth that we're working on here. Lower tooth. These are the upper teeth. Obviously, you can see I've practiced on them before. I don't have the Typodont holder thing, so sorry about that. I'm not going to wear a mask so you guys can actually hear me. I'm not treating a live patient. This is not a COVID scenario. Don't give me a hard time. Okay. So step one, let me open everything, set it up. Sorry for the noise, I didn't open it before. Everything needs to legally stay in their packets until your patient is sitting in a chair. If your dentist isn't doing that, that's illegal. That's a requirement. They're not allowed to open anything, so that technically if you ask them to show me an indicator, everything's sterile. Okay. So I'll tell you what all these things are as I use them. The only thing I won't be using today is a rubber dam. I'll show you what that looks like though. Okay, so step one, we're gonna numb the patient. We already went over medical history. I confirmed that I understood the medical history. I know that this patient is taking an anti-seizure medication. This patient is at a slightly higher risk for having a seizure in my chair. If they have a seizure in my chair, what do? I lay them back and I hold them in the chair. I don't want them to fall. Sorry, my nose is super itchy today. Again, struggling. I don't want them to fall off the chair. Patients who are having seizures, you can have a stress seizure, so you can have a hypoxic seizure. You can be really worked up, really stressed out, stop breathing, forget to breathe, and start seizing. Don't want that to happen. Usually happens right when I numb them. Okay, so I'm going to set up my anesthetic. This is our scary syringe that we use. Showing my TikTok people, if you're following me on TikTok. Plug them in. I've made videos on why our syringes look so scary before, but I'll reiterate. We need to see everything. So I have a certain gauge and a certain length because everything that I'm aiming for is, I have to go through several layers of tissue to get there. I don't have a skull here as an example, but I have to go through many layers of tissue to aim towards the lingula, which is where the inferior alveolar nerve enters into the mandible. If you have any anatomy background, I need to see my carpule. I need to see my anesthetic, and it needs to be easy enough to take it out and reload it and add more. Different patients require different amounts. Patients on Dilantin, patients who smoke weed, patients with red hair always require more anesthesia than other patients. Some patients also have faster metabolisms. They might also require a little bit more. So I need to be able to pop this out like so and reload at any time. What I'm using is lidocaine. We don't use Novocaine anymore. That's just an old name brand. Nobody's used that for like 100 years. Just getting like 50. Lidocaine, you've probably seen that, in your medical training at any point. Seeing this clear carpule allows me to aim and then pull back. Nerves always run with veins. So and arteries, they run in a sheath usually. So when I'm aiming for the sheath, I'm aiming for the nerve, but I might be in the vein. I don't want to inject this carpule into the vein because it's going to have epinephrine in it. If I sink epinephrine into a vein, it's running right to the heart. That patient's going to have some heart palpitations. Their heart's going to race. It's going to freak the patient out. It's going to freak me out. Now they might faint. Now they might also have a seizure. Who knows? Okay. Before I do that, I'm going to give them some gum number. I love gum number. It's fantastic. I'll dry the tissues. Drying the tissues. Smearing some gum number on it. It's just a jelly. This patient doesn't have any feelings, so I'm not going to do that. Okay. Needle safety, I always pop my needles off like this. I don't pull from the top because I could pull from the top and stab myself. We don't ever do that. I pop them off like that and make sure it's loose. I can tip it down or I can flick it off. We do recap our needles in dentistry. I'll go into that in a second. It's held like this is how we hold our syringes. If this is my patient, I'm aiming towards their lingula. This is the lower jaw. So I have to aim across from the premolars all the way over and inject that material, squirting it right into my water. That's cute. Right into where that nerve lives. Now I'm aiming blind. I don't have perfect, well, that was bad recapping, sorry. I don't have perfect knowledge of where that nerve is. Sometimes I need to aim it higher or lower. It is what it is. Do what I say, not what I do. Better needle recapping. Put the cap on the table and slide it up. I do this all day, every day, so I grabbed it, sorry. If you're learning, you have to recap like that. Okay. Anesthetic takes about 7 minutes to set up in this nerve trunk, particularly upper teeth are much quicker to numb because the maxilla is less dense. The mandible is the most dense bone in the body. So I'll wait. I'm talking to the patient, making sure they're not fainting. The most common time for a medical emergency is right after we've injected anesthesia. You should be waiting for your patient right after you inject anesthesia. You want to wait with that patient for 3 to 5 minutes to make sure that they're not having any sort of reaction. All right, patient's numb. How do I know? I always check. Not every dentist does. Oh, I'm sorry, I didn't give a long buckle. There's a different nerve too that's going to numb the tissue here. So I'm so used to doing both together. It's weird on a false patient. So I'm going to take my sharp instrument. This is an Explorer. I'm going to do the thing that the people do in those YouTube videos. This is an Explorer. It has 2 pointy ends for different locations. If I'm checking the top of a tooth, I might use this one because it's a little more curved. If I'm checking the side, I might use this. And I'm going to poke the tissues. If the patient can't feel me poking their tissues, fine. Usually with the inferior alveolar nerve block, also the lip goes out, cheek goes out. Sometimes the tongue goes out. That's the lingual nerve. That goes out as collateral damage. I don't care if the tongue can feel or not. I'm not cutting into the tongue. Let's say the patient is numb. What do I do next? Usually I place a rubber dam. Rubber dams have been sexualized in the media. I don't know how people use them for those things. This is a dental rubber dam. We punch holes in it and we stretch this over the tooth. It kind of acts like a mask. We stretch it over with a frame. I'm not going to do it here because you won't be able to see as good if I do that, I think. I always use a rubber dam when possible because rubber dams are going to keep my area much drier. I need almost perfect isolation. I need an almost perfectly dry surgical field in order to have my material bond to the tooth structure. It's super important to have it nice and dry. Some things don't require rubber dams. Fillings usually do. Not every dentist uses them, and I think that that's unfortunate. We were all trained to use them in dental school. We all know the research about them, but they take extra time. Patients don't like them, so a lot of dentists just skip that part. Their fillings last shorter amounts of time statistically if you don't use them, so ask for one if your dentist isn't using one. That's my 2 cents. Okay. Next step, patient, we'll pretend, is wearing a rubber dam at this point. Patient is numb. I always take my time with my patients. Oh, hello. I wear gloves today. I'm going to set up my burr block next. I can tell it's mine because it has an A on it. I know it's ghetto. These are all the different things that I can cut with. They're all different shapes. They all have different purposes, basically. Some are polishers, some are cutters, some are diamonds. Yes, they have diamonds stuck to them. I'm not going to go through them. They're not super interesting, I don't think. I also have a new cutting burr here so I can cut a little faster. I'm going to put it into my hand piece. This is not called a drill. We never use the word drill. It's called a hand piece. Y'all call it a drill. Freak yourselves out. Okay. And I'm going to tell my patient, I don't know, what am I going to call her? Lisa. Lisa, I'm going to start. I'm going to go for a count of 10. I want you to raise your left hand if you can feel anything at all. I don't want my patient to feel anything, but I also want my patient to have an out. many patients have dental anxiety, and something that really helps them with dental anxiety is giving them that out. So count for a count of 10, cut slow at the beginning, make sure that they're not feeling anything, gain that trust, and then proceed. They raise their left hand because I'm working like this usually, and I can see the left hand go up. I can't see the right hand go up. It'll go right behind my head. It's a safety thing. They should always raise their left hand. Okay, Lisa, I'm going to start. Raise your left hand if you feel anything, or if you're uncomfortable or need me to stop. My patient at this point, or my assistant at this point, is suctioning. I'm holding my handpiece. This is kind of weird because I'm trying to show you guys. So if this is my patient, I'd really be coming from this side to access the tooth. But I have to cut from above. I can't cut directly where the filling or where the cavity is. I have to cut from above and cut down. I'll zoom in and show you that. You can see my light is right on the tooth. And this is going to spin at like 5,000 RPMs or something like that, and cut directly into that enamel. 9 and 10. Great, Lisa, you didn't feel anything. Now Marty into dentin. Enamel has no sensation. I want to cut into dentin in that first 10 seconds. If she's going to feel anything, she'll feel it right then. Again, dentin has sensation. Okay, Lisa's not feeling anything. If you want to see where I started, I've cut a hole directly into the top kind of back part of that tooth. All right, let's open that up. I need to open the contact area.
So now she's gonna feel something?
So she would at this point, yeah. So I've cut basically here, if this is the tooth, I've cut down to about here. I've cut into dentin. That's, she would feel that for sure if she wasn't fully numb. All right, now I'm gonna finish. I'm already about halfway prepared, and that only took 10 seconds. Okay, almost there. This is plastic and I don't have my water on, so it's burning a little bit. Sorry, guys. Okay, so I'm cutting a box. I'm doing what we call a slot preparation. Let's see if I can. I don't even have a pen in this room. Well, hold on. I'll make it a little bigger for y'all. So if this is our tooth,
the light's making it like
weird. There you go. Oh, I'll zoom it in.
there you go. Now we can see it.
Okay, so these are the cusp tips. I know what they look like. I'm sorry, I'm not good at drawing teeth. This is the fossa. This is the deepest part of the tooth. This is where I'm kind of aiming when I'm cutting. I'm cutting directly in the, this is this. I'm cutting here, down. The cavity is starting between adjacent teeth. So the cavity is starting here. I'm trying to access that. I can't access it this way. I have to access it from above. So I have to cut out this whole section of tooth structure. It happens, it's hard tissue, that's the only way I can access it. I have to prepare a box. Cutting out all of that. I've got my box, it's really small, so that's why I drew it bigger for you. And I need to make sure I've broken contact. The dirtiest spot in your mouth is where two adjacent teeth contact each other. That's why we're always giving you guys a hard time to floss. Floss is the only thing that can clean where two adjacent teeth contact each other. There's really only like a 2 millimeter by 2 millimeter place where they're actually touching adjacent teeth. And the floss is the only thing that's going to clean that. So keep it clean. This is where cavities almost always start. That's why we take cavity screening films too. It shows us that contact area. Okay, so I'll try to show you my tiny little tooth here. If you can see here. So it has a little box cut out of it. Can you see that at all?
Yes.
You can see gum tissues too. You can see I've broken contact. Let's see if I can. I didn't practice on a Zoom thing before. See that little cutout here on this tooth? Maybe
It's
not.
like small.
It's really small. Everything we do is in fractions of a millimeter. So this is my little cutout here, my little hole that I've cut. I also made a TikTok doing a similar thing like this if you want a little more zoomed in visuals. Okay, let's fill it up. What do I do next? How do I know I've removed the cavities? Well, let me make sure. We have a different instrument. This is a slow speed drill. If you ever had a cast and you had your cast cut off, the cast cutter can only cut hard tissue. The slow speed for us can only cut soft tooth structure. So I'll take my instrument, I'll dip it in where that cavity was and really give it a go. Great. It didn't remove any. I removed all the cavities. That's great. Sometimes that happens. Sometimes I'm digging and digging and it's just mush. The interesting thing about dentistry too is that I can't always see the cavity when I'm in there. Sometimes cavities are the same color as natural tooth structure, especially when they're virgin. They can look the same. So I need to do it by feel primarily. I'm scooping out that soft tooth structure. Sometimes they're green, sometimes they're brown, sometimes they're dark, sometimes, you know, they look different, sometimes not. So I do that primarily by feel. This only lets me cut soft tooth structure, which is great. Now this is all prepared. How do I know that it's prepared? I have a flat floor. I want the floor of my preparation to be flat, not sloped, so that my material sits upon it. If there's a slope, it's going to slide out over time. The pressures, the bite forces, I need, back to physics, I need kind of a flat spot for that pressure to go directly down upon. So I check with my instrument. Yep, it feels flat. Again, everything's really, really small. This is mostly what you guys would see if you're actually shadowing me. You're not really going to see the tooth too much because you'll be in the corner of the room probably. So it's flat. I need to make sure that the contact, that I've broken that contact, because that contact area is the dirty spot. I need to get below that to make sure I've cleaned that out. I also need to break contact kind of elsewhere so I can fit the rest of my instruments in. Good. He's ready for a filling. She's ready. I think my patient's a girl. Okay. So this is a probe. This measures gums. I use it to measure the flat floor. I can take my instrument and scrape, make sure that it doesn't catch any soft tooth structure. This Explorer, if I poke along your teeth and I dip into a soft spot, again, it could look the same, but if I'm poking in and I stick my instrument and it can stay, that's a cavity. Okay, so we're all prepared. Now what do we do next? How am I going to build that contact back up? Well, I'm going to find the correct instruments to do so. I'm going to take this little matrix. A matrix is something that's really, really small too. Everything is small. It's this little metal piece, and it's going to basically put a separator between the adjacent teeth here. I need to do that so I have something to push against and create that contact. I'm also going to take a wedge and I'm physically going to separate the teeth, physically separating the adjacent teeth, so again I can push that material in and build that contact back up. This is what that whole thing looks like here. Wedge and matrix are in. I'm going to take this band and grab hold of it. This is just to keep everything steady. Humans are moving targets, so they're always moving on us. I can't just slide these in and leave them alone. Except it doesn't want to fit on my Type It On, so love that for me. There we go. Maybe. Sorry, sometimes things are different on these fake teeth than real humans. That's why dental school is fun too.
So do you learn about all these tools that you're using in dentistry?
We have to, yeah. So we learn, I don't know, hundreds of procedures probably before we treat patients. And that's the big difference between med and dental, is that we have to do a ton of procedures during our training too. Med students learn that kind of later in their training. Okay, so this is what that whole setup looks like. It has a ring on it. That ring is grabbing hold of all my little pieces. My little matrix is separating these adjacent teeth, so I'm not gluing them together. This bonding material sticks to tooth structure, right? So I don't want to glue those two guys together. In different countries, that is a technique that they use. It's not something that we do in America for many reasons. I also took this instrument, it's a ball burnisher. It basically is a little round guy, and he pushes against, or I push him against this matrix to really push him and work him into the adjacent tooth. So I have a nice smooth curvature there, and I can build up my material. Okay, Now the fun part, I think. Let's say that I dug pretty deep. This filling was really big. Actually, on the x-ray, it was broken through the enamel and into the dentin. Sometimes, so our x-rays don't show us all the tooth that we need to remove because soft tooth structure is not always going to show up on x-ray. X-ray only shows us what's missing, basically. So say this filling was really deep, it wasn't, but say this one really was, and I expect the patient to be sensitive afterwards. I use a desensitizer. We call it microprime. Desensitizing agent. It's similar to the active ingredient in Sensodyne toothpaste, actually. So it kind of it blocks the dentinal tubules. It kind of calms them down. I'll take this and literally just scrub it in here with my tiny little brush. Taking my tiny little brush, scrubbing it into my hole. And I'm supposed to do that for 1 minute. Nobody ever does it for a whole minute because it takes too long. Patients hate that. I don't have anything to spray this. Hold on. I thought I fully set up, but I'm missing like random things. Here we go. Okay. Then I'm going to dry that out. I'm not going to rinse it out. I'm just going to dry it out, spray it out. I will rinse in a second after I use my etchant. So if you know, this is not a syringe, this is an acid etchant. There's different types of etch. This is 35% phosphoric acid etch. You don't want this getting in a patient's eye. I always tell them to close their eyes for this part. You also don't want it to get on their tongues. It tastes nasty. I'm going to squirt it in. And it's going to etch the internal aspect of this filling preparation. So it's filled with that blue stuff. It's blue so that we can see it. There you go, you can kind of see now. It's blue so that we can see it, and then I can see if it gets on the tongue or something like that. I will keep that on for 15 seconds. I don't want any longer than 15 seconds. 15 seconds is the optimal amount of etching for dentin. I can etch enamel much longer than that, but I get significant dentin sensitivity if I etch longer than 15 seconds. So we'll pretend I just counted to 15, and I rinse this out. Now, normally I would have an assistant suctioning all this schmutz out of my false patient's mouth, but I don't have an assistant here. She didn't want to come in at 9 o'clock at night. Don't blame her. And I'm going to lightly dry it. I'm not going to over dry this. Barely going to make sure it's dry. Now it's etched. So if you picture glass etching, it creates a little microporosities in the glass. Same thing, really microscopically, we're creating microporosities here for the bonding material to sink into the dentin tubules and the enamel rods. So that's all etched. What do? I jump immediately to bond. This is our bonding material. It's super expensive, so don't waste it if you're shadowing somebody. Don't leave this bottle open, I'd kill you. It's one of the most expensive materials in our office. This is basically the glue that connects the tooth structure to the actual filling material itself. So I take this little drop of bond, again, I take my little scrubby brush here, and I scrub it. And make sure that I touch my whole preparation here. It's really tiny, I know. Everything I do is really small all day long. If you don't like small things, don't go into dentistry.
Yeah, it's like microscopic.
2 millimeters by 2 millimeters, you mean?
Yeah.
It's like a football field for me. Okay, so I scrub that. I'm gonna dry it quickly, quick burst of air. They say that burst of air is gonna push it into all those little microporosities that I created with the etch. I don't really know if it does. Some doctors spray the air, some don't. It's a whole thing. Then I'm gonna light cure it. If I have girls following me, you guys have all probably tried gel manicures at some point. Gel manicures, gel nails are light cured. This material is the same basic structure as gel manicures. Actually, OPI, the nail company, was a dental company first, so they kind of created this material and then transferred it to gel. So I'm gonna light cure it. Blinding y'all, I would light cure this for 20 seconds. I'm not going to do the full thing. You don't need to watch me light cure it. Once it's light cured, sometimes, again, if it's super deep, I'll make a judgment call. This one's not. I might flow a low viscosity wait, yeah, I always mix up my viscosities. Low viscosity or very flowable composite material, tooth colored filling material. I'm not gonna here, kind of for time's sake, I'm gonna squirt with my gun. We don't ever say pass the gun. Again, I told you I worked in a federal prison. We don't really call this a gun, we just call it material. Pass the material. And I literally squirt it in and I layer it. It's super, super small. So I've squirted this stuff in and I can pack it. It's like a putty. I'll show you. So this is a big wad of it. I can squeeze it and stretch it and play with it and mold it into sorts of different things. This putty is what hardens into that filling material. So there's a little putty here. I squirt it in layers because it does shrink slightly. I pack it in, push it in. It does shrink slightly, and that can cause pull and tension on those dentin rods or dentinal tubules. The dentinal tubules do have live components of them. That's why dentin has sensation. I don't want too much tension on those because then you'll have post-operative sensitivity. So I need to layer it, make sure that I'm not, creating a ton of pull in all different directions. I need that pull to just happen on this side and then happen on this side. So I'll put one layer. This looks so bad because it's in like a fake tooth that doesn't really fit my my instruments anymore. This was one of my dental school Typhonons. I've abused it, as you can tell. All your stuff in dental school gets so abused. Also, put your name on everything in dental school. People steal stuff. No lie there. If you see that my light has my name and phone number on it. You can get little labels for like kids' clothing. I don't know. It's a good idea. All right, I'll light cure this for a full 20 seconds too. This is the most boring part of my job, I swear. I'm literally sitting there and I have no patience at all, if you can't tell. I sit there and my patient's just waiting. You have to wait the full cycle for it to do anything. And I'm bored and I'm tapping my foot. I'm like, come on, listen to the bad songs on the radio. Why do dental offices always play like the worst music? It's supposed to be calming, is it? No. Okay. I'm going to do another layer here. I'm going to shape this to look like a tooth. I know everything is super small, but if you remember, I cut out this whole section. I need to shape it back to look like it was before. So that's what I'm basically doing. When you shadow me in real life, because you're all going to DM me and actually shadow me if you live in Boston, right? I'll show you closer. We'll do a whole practice. I'll make you do this instead. How's that sound? I'll do one and then you'll do one. On a fake patient, not a real patient. I'll do one on a real one and then you'll do one on a fake one. Okay, so I'm carving this away. Really, really small. See how I'm kind of getting that shape back? You remember the hole that once was there? Kind of getting that shape back. Smearing that schmutz up in there. Taking this instrument, my Explorer, and kind of gouging out this excess, removing the excess, shaping the distal marginal ridge. If you are a dental student already, you would know what that is. You should know what that is if you pay attention in any of your classes. Also, something I didn't explain about dental school, you don't have to go to your lectures. I went to every single lecture because you pay so much money. I don't know why you wouldn't. But that's something you guys might not know about med and dental school, is that they record every lecture. So you can actually usually watch your lectures. You guys are the Zoom generation. You can usually just watch your lectures from your bed at home.
It probably wasn't a difficult adjustment for those who would prefer to watch it online.
Yeah, you save a lot of time. You save a lot of commuting time. Okay, so if you can see, I wish I had like an influencer's camera. Do you see the material up against that metal?
Yes.
So it's filled in. There's no more hole. That's what a filling is. The cavity is the hole that the bacteria form. It's actually their acid that forms so the bacteria, if you guys have ever taken a class and you learn about bacteria, I'm going to cure this too. You know that bacteria ferment. So bacteria eat, sugars, and then their byproduct is acid. You do need to memorize fermentation and glycolysis and all that stuff for dental school. It sucks. Metabolism's the worst. but their byproduct is acid, so that's what eats into the tooth structure and actually creates that cavity or that lost tooth structure. Okay, so now this is filled. So I've put the tooth colored filling in there. I'm going to remove all this stuff that's separating the two teeth. Taking my little tweezers here. Actually, I have no idea what these are called. I don't think they're called tweezers. Actually, I think they're called V3 forceps. It's a brand. And you can tell I have a tight contact because I really have to pull here to remove this little band. I'm like really struggling to pull this out. That's a good thing. You really want tight contacts. If you have loose contacts in your mouth, loose contacts are food traps, so we don't ever want that. So now I'm technically supposed to cure again. I'm not gonna because, you know, time. But you can generally see that that tooth no longer has a hole in it. It's filled back up. This is the tooth that we're working on here, this back half of it. Filled back up, and now we're gonna cut it back down. Some schools teach you to fill it to look almost as much of a tooth as you can and kind of build it correctly the first time. Some schools tell you to just throw it in and cut it down. I was taught to sculpt it. Did I sculpt it right now? Not really. I'm going to take a carbide. This is, it polishes kind of while it's cutting. And I'm going to shape it. I don't want to have any overhangs or any places that your floss is going to rip or your, you know, teeth are going to get stuck or whatever. It needs to be super smooth. Also, the worst part of being a dentist is that patients are really sensitive. The reason patients don't like going to the dentist is the mouth is one of the most sensitive parts of the body. If you've ever heard of the human homunculus, there's different parts of the body that are more sensory oriented than others, the eyes, the mouth, and private areas. So if you have just the slightest bit of your filling is too large, thick, or whatever, the patient's going to be really uncomfortable. So I'm going to shape this with other shapers here. Start to finish in real life, this whole thing start to finish would be about 20 minutes, including anesthesia. So that tooth is built back up. It's not polished. Polishing is our last step. It's shaped. Actually, last step, let me check the patient's bite. I take this carbon paper. My patient doesn't have a bite, so I'm going to kind of force the bite. And I have them chew, and they slide their teeth around, and they're really chewing into it, making sure that they're not just hitting on my filling, and they're not. So if I look at these bite marks, these blue marks on the buccal cusps is normal for lower teeth. It's not, I don't know why my patient didn't bite on this tooth at all, but they're not just biting on my filling. If they're just biting on my filling, then I've done a bad job. It's too tall, it's too high. I stopped using that word when I worked in prison. If you say, does it feel high? Your inmate will look at you and say, no, doc, my tooth doesn't feel high. You didn't get me high, whatever. So does it feel too tall? I'm going to polish it. This is just a buffer at the end. Tooth colored fillings, composite fillings are basically plastic. So they're resin, they're plastic. They need to be polished with a high shine or they're going to get micro fractures. So we always have to polish. Good. They're polished. I'm going to check my floss, make sure that I have a contact. And, oh, I'm not ripping floss here. That snap is a good thing. You hear that?
Yeah.
That's what I want. Patient likes it. They're not catching their tooth on it, and that's it. Good to go. Tooth is back to its original form. That's a filling in all its glory. If you come shadow me, we'll do a ton of those. We'll also do other more fun stuff like surgery. If you have any questions, you can drop them or shoot me a TikTok. I'll stay on TikTok live for a little bit longer if you want to throw me some questions. And thank you for having me, Club Med.
Thank you, guys. Since this was a little bit over time normally, we will make this. We'll just round it up to 2 hours. There was a question about that. But other than that, I mean, that's it. I mean, it was a really good session. I mean, I thought that live session at the end was really cool. Like it puts into perspective of what an actual, like how many things they're using. But that's
A
it.
lot of different things. My table always looks like this when I'm done too, my poor assistant. All right, have a good night, guys. Thanks for having me. Again, follow me on TikTok if you want to ask me questions. I'll stay on live here for a little bit if you have questions specific to this stuff or what we talked about tonight.